Well, so what we're talking about here is they're going to videotape it, and then they have a QR code that they build, and then the video's on YouTube, and then all the nurses that are not here, they're required to go watch it, so they can still get all the same. You know, it's not live, but the only thing they can't get the benefit of is watching the asking questions basically. So they don't get a chance to ask. All right, guess this is a good spot to stand. Wait a couple minutes to get going.
Is that where you want the camera?
Yeah, looks good to me.
I can get closer if you need it.
I will. What we'll do, we'll plan this. So when we do the dressing change, we'll bring the mannequin to the video.
Very well.
So like if you can hold it for me and then we'll just so they can see better. So you all just let us know when you want to start.
Go take a check on this.
Yeah. People.
Oh, thank you, Honor.
They're redoing the courtyard, huh?
Are they?
That's crazy.
No, this is a different courtyard.
Is it?
This is the one that you can only get through a window, so it's only maintenance.
Are you serious?
Mhm.
Wow.
I
I
know.
thought that was the courtyard where like,
No,
the horseshoes and.
I think it's just right. I think it's on the other side of the wall.
yeah.
Why don't they let patients access this?
I don't. They literally because there's a window.
Sorry.
I'm sorry, I'm trying to mute myself.
So Amber or anybody else, you can feel free to jump. Is there anything that has come up before we start that you think we should touch on? Today's topic's gonna be postoperative care for thoracic surgery patients.
Heavy on the documentation, what's expected
Okay.
would be really helpful.
Got it?
Allison, Jessica, any input, thoughts?
Anything you want me to include? That topic is just postoperative care for thoracic surgery patients.
I think I would notice it.
Yeah. Notice any other follow-ups? Yeah, I know we've had just.
Dressings is the
dressings
biggest
that-
one.
I know you covered it once, so if we could cover
We'll
that.
do that again.
Yeah.
Dressings, like he said, yeah.
Yeah, and then you'll see today, we're gonna talk about the importance of ambulation. So.
Okay, there's 24 drawings.
And same
It's got a
reminder.
tray,
cameraman.
So people may think,
Too bad Amber's not here.
This is the old,
Yeah.
the old shiny, now they're different.
Yeah,
Now, you know why? Because before you clean it, you have to remove it. So you would not be able to connect this to the bench, guys. And now they changed it so you don't have, you have the endo cannula, but this.
Yeah, it stays
Stays there, yeah. And this area stays here, and then the endo cannula is. Yeah, so you can remove it, just connect the patient back. So that's why they changed it. You know, keep the patient without ventilating for a while.
okay, thank you.
Yeah, you really have.
Nick was my best friend earlier, so I had to
Now, the cameras are different. Have you seen the new ones?
The new
The new
channels?
trays? Yeah, the new cameras.
Those are kind of gray.
Yeah, they're just,
Like, see-through.
yeah,
You can see like access the skin underneath.
Yeah, it's true,
really
yeah.
nice.
nice, but they also shoot that.
Allison, do you mind
Should we
going
start?
virtually on mute so that if anybody tries
yeah.
to come in, okay, so.
Yeah.
Like, just like that?
Yep.
Okay, thank you.
so where are these people at? Phones?
from home. Yeah, I
Oh.
sent the invite to
Oh, nice.
every nurse,
Oh,
not just
wow.
ones that are here today.
1, 2, 3, 4, 5, 6, 7.
They might continue to trickle in.
Yeah.
And they can hear us, we just can't hear them.
They should
believe
hear
so,
us.
yeah.
They can hear us?
So
Okay.
we can't talk to that.
But can they do the thing at the end where they raise their hand up on the thing and
Yeah, we can use
we
this.
can get questions? Okay.
Yep.
Can you put that in the chat? Like, just tell them like, please at the end, like if you have a question, don't be shy, raise your hand. We'll try to get to everybody. You know, just since they're not here.
Yeah.
Let's see, we have this thing. Have you seen this from Atrium? Can simulate air leaks. Isn't that cool?
Yeah.
They got it from the back. Yeah, it's pretty cool. There's a 1, there's a 2.
Are you sure just with?
I know, well, yeah,
That's the way to go.
yeah.
Wow.
We get started, Allison?
Think so.
Yeah.
People might still be kind of trickling in.
Okay.
I'll admit them.
Y'all can sit
Great.
down if you would like. Just all y'all.
Okay.
All right, so we're recording. You ready to go? Good to go?
Yeah.
Okay.
Ready to go? Yep, I can see from my end.
Okay.
All right.
Yep.
All right, hello, everybody. Welcome back. This is our second course we're doing in service for North and much of the hospital. My name is Steve Rosenthal, one of the PAs with thoracic surgery, and Dr. Agote Green's here today. We'll introduce you to the surgeon. I'll get a chance to talk to you as well. Today's topic is going to be on postoperative care for thoracic surgery patients. So what I want to do is start off with kind of a unique story. It's happening kind of in real time right now. So basically, we had a patient come into clinic a few weeks ago. She traveled all the way from Africa here, didn't really speak a whole lot of English, really nervous about the US hospital system compared to back home. She was from a very, very small village in Cameroon. And basically, we evaluated her in clinic and ultimately decided that she needed to have a lobectomy done. So we scheduled for surgery. Again, very, very nervous about the whole process and what was going to be entailed. Not a good grasp of English. So, you know, even though we had interpreters and her family, nervous going in. Yesterday, she had her lobectomy done. We did it on the robot, and she's actually going to go home within 24 hours of surgery. She ambulated the night of surgery multiple times in the halls. If you look at her, you wouldn't even imagine she had surgery, and she had the entire left lobe removed of her left side. So just a fantastic success story, able to discharge from, quite a large surgery within less than 24 hours from start to finish. And so Dr. Agote Green did a, fantastic job with the resection and minimal complications. And I just want to share that story with you so that everybody's excited about, what's possible if the patients kind of hit every goalpost and they do what they're supposed to do after surgery. Now, had she not got out of bed and really walked multiple times the first evening after surgery, this may have not been possible. And then she would have been in the hospital another day, which still would be impressive post-op day 2. But that's kind of what we want to talk about today is what's possible where people can come in and the next day go home from quite a large surgery. And the whole team here on the floor, all the nurses, you're a big part of making that happen. Talked to the nurse last night. It's a fantastic nurse that already reported, minimal chest tube output and patients already ambulating with no pain. So we're gonna go through all that. So with that being said, we're starting up the new program. This is week 9 or 10, and you'll start to see more cases that will be cancer resections that are either done robotically. They could be open cases that are large cases. If anyone was involved with the case that was at the end of the hall, the large solitary fibrous tumor, that was quite a big case that we did. And so we want to focus on what's important about helping these patients progress through their hospital stay and get home as soon as possible with the least amount of complications. So when they come up from the PACU, one of the things that's most important is once the anesthesia is worn off and they're safe to ambulate, we need to get them up out of bed. These are not the type of surgeries that you want to baby them and let them stay in bed and kind of feel sorry for themselves. We really want them to ambulate to help aerate their lungs. It also helps mobilize the fluid so that that can drain out of the chest, and their lungs have a better chance to aerate and re-expand. So that's super critical. That may be a new change for people to get used to, pushing patients really hard to get up and ambulate. You'll see on a lot of my notes I'll put in there on the decortications that we do. Patient must ambulate 5 times, and it's post-op day 1. And that may be a little bit nerve-wracking for the nurses, like, oh, they just had this big surgery, they got 3 chest tubes, oh my gosh, But as long as pain's well controlled, we want them to get up and mobilize. And believe it or not, some of the best medicine for reducing that pain is very counterintuitive, and that is to mobilize them so that their pain will go down, believe it or not. So it's against what your brain's telling you, but if you push them to move, they will have less pain. So mobilizing is going to be huge. We will fluid restrict some of our patients. That'll be in the chart. The chest tube output, we want to retouch on that. That's something that is critically important. We've seen a great job lately with people charting in the actual lines, tubes, and drains category where they have the container level and the 4-hour output. So just be conscious of making sure that you always change or update the container level, which is going to be the total in your atrium. So that'll be the total that you know here. And then you'll just do the math on the 4-hour period and see if it's 40 out, 100 out, 200 out, whatever that math is. But the container level is very important for us to be able to double check the math. So sometimes we've seen people put the output of 200 or the container level, 1600 in the output. And then we're kind of really nervous when we're chart checking that they dumped over 1 liter, in 4 hours. So be mindful of that. The other thing we do when you do your first check in the morning, and then you do your subsequent checks and you come in and interact with the patient, we want you to check the chest tube. And it's really important that you check it from the site coming out of the patient. And that, sometimes is really tough when you have 3, but you need to run the line from where it exits the skin all the way down to the atrium. You want to check for any connections that are loose, make sure that those are all secure. You want to make sure that there's no kinks in the drain. And these are all things that we've found. I would most importantly, if you ever get a chest tube from an outside hospital, you're going to have upwards of like 80-90% chance that there's going to be connections loose. Things aren't really well connected, kinks. You have no idea what's underneath the dressing. So I encourage you, whenever you get a patient from an outside hospital to transfer, we have one coming in today, as a matter of fact, from Seton Southwest, as soon as we get a bed for a pneumothorax, just take down everything. Just take down everything that they've done and then redo everything so you can assess. When you assess and you take off the chest tube dressing, Amber, if you want to help me, we'll bring this a little closer. So we'll bring this up to the camera here so you all can see. So we don't have it on this one. Maybe for the next class I'll do this, but you're going to have an anchor stitch here where the chest tube is tied into the body. So you want to make sure that that's in place. And then the tube's going to have suture coming up the tube. You want to make sure and use tweezers or your gloved hand. You can make sure that that's tight and the tube doesn't move. Make sure there's no kinks in it. And then as far as the dressing, what we want you to do is we want to simplify it. There's no more zero form that we're using on our service. So from now on, we're simply going to use two 4x4s. Just going to take a 4x4, fold it in half, fold it again. One goes under, and then one goes over. And then Amber, if you want to hold that for me.
Mm-hmm.
And then just a simple tegaderm on top. All right, so we've got that secured. And again, no zero form. We're getting away from that. That's going to be a big culture change so that everybody kind of gets used to that. And then after you've done your dressing, this is one thing that we're still working on to get everybody on board with, is we want to use this 1-inch silk tape or nylon tape. says Durapore on it, but take about an 8-inch piece of the tape, and then what you're going to do is we'll simulate it. It's not going to, in real life, you'll put it where it's kind of in line, but you're going to, you see it?
Yeah, it's the focus keeps kind of changing.
Oh,
So
okay.
I'm trying to, there we go.
That's what it
So you'll take the 1-inch tape, you'll touch it to itself, and then the patient. And that way the tube has the ability to go to the front and the back, has less chance to get kinked, and it won't rub a hole in the patient and they'll get those nasty blisters. And then it's a secure point so that the patient's notified before it pulls at the suture point, and you have less chance for the tube coming out. Okay, so put this back up here. And with that, I'll introduce Dr. Agote Green, our new thoracic surgeon here, and the floor is yours. You can add any pieces. And
But first, I want to thank the team because they've done a great job, and the idea is to keep on increasing the number of cases. We'll slowly ramp up, and being able to have these results where the mode is sending patients on post-op day 1 after scheduled lobectomies. It's all a teamwork approach. So if you help us, then we will be able to do this. We'll use smaller drains. They're easy to handle, but the patients have to move, before we send them home. So the patients walking the day of the surgery is very important. Than the next day, of course, we want to make things easier for the team and for all the nursing staff, using special walkers where you can hang the plurivacs or the chest drainage systems, and making things easier for you as well. We understand some patients are difficult to get out of bed, but the idea is to make it easier for you and safe. There's some walkers that they have little flaps that fall down, and the patient can sit before they fall. So then we need to get those here in the hospital, especially for patients that we want early ambulation. So I just want to thank you, and be sure to ask us any questions you have. We're always walking around, and Steve is here, has been here for many years. So I really appreciate all his work. And let us know if you have any questions with any dressings and the post-op pathways, whatever we can help. And be sure to come close to us and ask us any questions.
all right.
Does anybody?
Yeah, go for it. No, if anybody has
gonna-
questions that's not here, please, a great time. Feel free to just raise your hand on the computer. We'll get to all the questions as well, and don't be shy.
While people are thinking about what questions they
Yeah.
have, I think a lot of our nurses like to know the why behind things.
Sure.
Can you further elaborate on why we would fluid restrict a patient with a chest tube?
Absolutely.
So lungs work better dry. So you see patients that have, and the first thing we talk to anesthesia, usually they're very experienced. So we tell them, okay, so no fluid on this patient. That means every patient that we do surgery on or some lung problem, they already have either heart failure or they have poor lung function. They might have COPD from all that smoking. So if you put a lot of fluids in patients, what happens is their lungs get soggy and they can go into heart failure. And that's when you have all these patients that now we need to use oxygen because they got 2-3 liters of fluid in the hospital. And then now you have to spend 3-4 days diuresing the patient. So it's important to fluid restrict these patients, use very small amount of fluid. If you see a patient that had a big surgery and then he has 5 jugs of water, we don't want that. We fluid restrict these patients so they're not in shock, obviously, but that we keep them dry so they can be off the oxygen. So always try to decrease the amount of oxygen in these patients unless they use oxygen at home. But that's a reason. Now it's different from patients that have esophageal surgery, which is also in the chest. But those patients will be handled differently. Those patients have way more IV fluids because they're not eating and drinking. And it's different in patients that have lung resections. You really didn't go into the abdomen. You didn't do a belly surgery, so patients can go out and quickly start their oral intake. because they didn't have any surgery in the belly, so they don't have an ileus. And so that's kind of the reason. And the other thing is, to really remember that we don't use Seroform anymore. There's no good reason that, and it's a valid question to us is why, if we've been doing this for 100 years. Well, there's no reason for the Seroform because they would tell you, well, that makes it hermetic. That is not true. You can't poke a hole in a balloon and then put some Vaseline and say, oh, now it's hermetic. That's not true. You put a Tegaderm, then it's hermetic. But Vaseline just makes it slippery. The tubes can be pulled out. So there's no real reason to. And it's an expense that is not needed. So,
and on that note, please make sure on your patients that are older, their skin looks like a little bit beat up. Use the Cavalon. If you don't know what it is, find it. It looks like an alcohol pad. It's red, white, and blue. It says skin barrier on it, skin prep. That is dual purpose. It's a small layer of second skin to protect their skin, and it also makes the Tegaderm stick nicer. So you do get that airtight hermetic seal like he's speaking of. And you can achieve that by using the Cavalon. Just need to let it dry.
And always have, you see a dressing that is wet.
Here.
Just it has to be wet and dry.
So here's the Cavalon. It's in the
Dry and clean.
clean supply. So find these, make these your friend.
And of course, if we have patients that have impalement tubes. Impalement tubes are chronic tubes, so they'll stay there for weeks. So, having on those patients really being hermetic is not the main goal. It's just to drain whatever is left in there, so we keep them. So those patients can have the paper tape or something that is less irritating, because sometimes they'll get a lot of redness, a lot of irritation from the glue. So we don't want to torture patients. We have to adapt to whatever is best for them.
All right. Did we get any questions, Allison?
Any questions?
No questions in the chat.
Okay. Gotcha.
I do have a question. Will
Yeah.
we know ahead of time about these patients so that I can try to get a discharge nurse or something to help ambulate them? Because with a patient load of 5 patients, it's going to
Right.
be difficult to ambulate that many times. So if we know we're heavy on a day, then I can
I
ask
see.
for getting like a discharge nurse that can
Yeah.
help ambulate these
Great question.
patients.
Do you have access to OR board, OR control?
I used to. I
Okay.
can see if I have that.
I would get access to the OR control. It's available on the intranet site if you just go through the applications.
Okay.
And then you just have to ask permission. And then you can just check that the day before.
Okay.
And just see, are there any, thoracic cases? 90% of them are going to come here. The other ones will go to MICU. So that would be probably the best way to check.
Okay, perfect.
And most of the patients that we're going to do like lobectomies and wedge resection, they usually stay on water seal, no suction. That's a big change.
Yes.
So just be cognizant that if it says no suction, that might be special with these patients that had a lobectomy. I tell them, well, imagine you have 2 balloons in a box and you remove a balloon, then there's going to be a space, because everyone freaks out. Oh, there's a pneumothorax. Well, yeah, you call it a space deficit. It's expected. And then if you put suction in it, then you're going to start having an airleak. So if you don't put suction, then the patient will have no airleaks, and then you can remove the tube early.
I will say the patient that came up yesterday, the
Yeah.
RC lab, it was really helpful. Put that big sign on it that said no suction.
Yeah,
I think
we're
that was
we're
really
doing
helpful to
special
nurses.
things. We're labeling all the chest tubes so that when they go in the computer, that first round, you'll see them labeled apical, anterior, posterior, and basilar. So that's been carrying through in the notes, fantastic. And as to your why, the reason why that's so important, not only the amounts, but the labeling is correct, and what's charted as the anterior and the posterior, is because we, the next day we got to figure out what we're taking out. We want to get those out one by one. So if they're charted in the wrong spot, or they turn into like left or upper or lower, like we have no idea what's what. So we try to label them when they come out of the OR. And then if we're consistent with that, that'll help us to, be able to track how they're doing.
All right. Great.
Any other questions?
Yeah, just one more. For the patients that are not gonna be on suction, just for safety measures, should we still have all the suction equipment at the bedside ready to hook up if needed, or is that not necessary on those patients at all?
Well, I think we could have it nearby.
Okay.
Of course, always think about the patient. If you're having a continuous air leak, then the patient might need to have, just give us a call and, if needed and you need to have to put the patient on suction, but it's rare that the patient will have a tension pneumothorax. There's a tube in there. So, it's always you shouldn't have a lot of air coming out.
And also make sure it's kinked, everything's patent, because if there is air building up in there, the last thing you want to do is have the patient decompensating and only to find out that the tube was kinked at the chest or they're laying on it. Those things can happen. And again, what I want to stress again is the outside hospital transfers that you get. You're going to get one today. I encourage you to look at it. It's 90% of the time not what we're talking about in terms of dressings, how it's secured. You should just count on the fact that it wasn't sutured in right and could very well just fall right out. Amber could tell you, Allison could tell you, believe it or not, there was a time on 4 North here where we had a lot of patients coming in from different ERs, and we had about 1 tube a month fall out. The nurse would walk in and chest tube was on the floor, and everybody goes into a panic. So we really made an effort to make sure they were sutured in better, but it can happen. And you don't want to trust them coming from an outside hospital or the ER. They're busy, it's fast paced. They can make some oversights, and that's why we got to double check.
Always check the connections, because sometimes they come to us and they have, they're connected, and then they put a bunch of gauze 4x4s in it, and then they put some tape on it. So because they said, well, there's some fluid leaking out. So if fluid is coming out, that means that air is going to go in. So you have to take everything down, make sure they're very well connected. A difference from the abdominal drains is that abdominal drains, they usually just drain fluid. And if they get wet, well, you connect it or you put something around it. But if there's a leak in the connectors or the system in the chest, then you're going to have air go in and then the lung collapses. So that's why connections in the chest drainage system is so important. It has to be a closed system with negative pressure. And the negative pressure is provided by the water seal, not really by the suction you connect. So the chest drainage system is working even if it's not connected to suction. It has a negative pressure, it's built in there. It has a little straw underneath water. So if you play with a straw and push some air into the water, and it'll bubble easily. You'll see it's very easy to push the air out. But if you try to suction fluid through that very long tube, that's very hard. So that's what happens with the chest drainage system. It's very easy for air to go out, but things cannot go in. It's a one-way valve. It can let things out, but it doesn't let things in. And that's why it's still working, even though if it's not connected. Now we want to apply suction and make it even suck a little bit harder. Then you connect it to suction. And the way it's working, because these are dry water seal systems, you'll see a little, when you connect it, there's a little bellow there that has to move, because they'll ask us how much suction, as much as you need for that bellow, that orange bellow to appear. And that's when now it's working. So it doesn't have to be a specific number here. Of course, you want to make it as less noisy as possible so the patient is comfortable. And those are better because before we used to put water in them and they were too noisy.
Yeah, I'm sure. You all remember, there was a time where we actually got the oceans up here and they're bubbling nonstop. The connector that he's talking about, just to let you know, so this is this one on this side, just so you know, that goes to the atrium. So that main one is glued. This one, you don't have to worry about so much. It's when this piece, the 5-in-1 connector this is simulating the chest tube coming out of the patient. It's this connection that you really want to check. What I do is you'll see I'll use steri strips or the nylon tape. We do a longitudinal piece and then a wrap at the top, wrap at the bottom. Remember the other day, Manny, we did that? Yeah. So this is the connector that's likely to come undone. And that's the one you want to make sure that it's not just going to fall off like that. And then that's how they get the giant pneumo.
You want to?
Yeah, we can show them real quick.
This is how we connect them. You make sure that they're very hermetic, and then we place one longitudinal like that, and then another one here, and the other one here, and that way, you know it's not pulling apart.
Yeah.
And you
So
can
that's
see
on
the
their list,
connector. You make sure there's no clots, there's no fiber in there.
Yeah.
So it makes it clean, neat. You want it to be clean and nice, and
Can I see that?
Sure. Okay. Well, awesome. Well, this is going to be a constant thing we're going to continue to do to try to get the thoracic service going and a well-oiled machine. And if anybody has questions, like you said, please stop us in the hallway. We're busy, but we're always available for questions. And if you do, we're happy. I love doing it. He's a great teacher too. If you have these more why questions, like just let us know, because I know sometimes that helps in the motivation. Like, well, yeah, they said do this, but I don't understand why. It doesn't make any sense. Just ask us, and then we'll help you.
and help us and let us know what you guys need. If you tell me, well, it's hard for us to make patients walk because
Yeah.
they're very heavy. It's just me. We want to help you get those walkers that we talked about. You know, if you tell me, well, because now I would have to be careful the patient doesn't fall. I'm concerned about that. That's very valid. How can we help you get all these things done? Because it might be easier for us than, you know, getting more help for you or getting the right tools, I think.
We're going to try to go to PT and get this amazing, super advanced walker. It's like the ones maybe you've seen upstairs. You rest your arms on it, but it also has the seat. So if they get tired, they can sit down. And you can put all the chest tubes on it. They're IV. That way you can comfortably and safely walk a patient with 3 chest tubes. And that walker that's tough. I feel for you. It's very tough to walk a patient with 3 tubes, and you know, everything's getting tangled and yeah. So man had one.
There's
Alright.
a question in the chat.
Yeah.
Laxmi said, what do you do in case of an accidental removal of tube or connector disconnection?
Sure.
Well, if the tube gets disconnected, one, you just connect it again and it's gonna work again. And now if it disconnected, it's that way it was not secured the way we showed. Because if it's secured that way, you would really have to yank on it to disconnect it. Now, if the tube falls off the quote unquote falls, you know, it has to be pulled pretty hard. So if it's out on the floor, then you just cover it with a gauze and then do a three-way dressing. You can put a Tegaderm on it, and if there's an air leak, air will go out. But then when the patient takes a deep breath in, it'll get stuck so it lets the air go out, but it doesn't let it go in.
And then call for help.
And then call for help. And then it might just fall, and then we might say, well, just leave it like that, and that's it. Maybe we'll place a stitch. Maybe we won't. It depends on why was the tube placed for.
Speaking of calling out, are y'all signed into mold assigned to the patients, or what's the?
So we're not signed into the patient,
Okay.
but we're working on getting the thoracic service under the on-call section.
Okay.
But you can just comfortably know that I'm here Monday through Friday, 7 to 4. If it's a thoracic patient we did surgery on, you're going to use the on-call system in Volt. Thoracic is listed, and it'll show the CV surgeon that's cross-covering. And if they need to reach out for something very, very specific, they can contact Dr. Argote Green.
A lot of the times the hospitalist will be in charge of our patients because we don't have a very big team. So right now they're helping us and we're working together to have all these patients. So, a lot of things will be covered with them, diabetes medication. So all the medical aspect of the care. And then of course, what we talked about, patients that get lung resections, we want them dry. So if you see a patient is eating and on top of that, he's getting 2-3 liters per day, that's not good. If the patient's eating, we always try to, the way you get these patients out of the hospital is, just logical things. The patient's eating, he's getting adequate intake. He doesn't need 2-3 liters of fluid every day because that's what gets them fluid overloaded. And that's when they have pleural effusions, and then the chest tube output is going to be high. So, that's another reason we want the output to be low. You don't want them to drinking 5 liters of water a day and their diet, and then they go into heart failure. So it just kind of, it all has to make sense. Great.
Is that all the questions?
Okay.
Yeah.
All right. We'll see you
Well,
soon.
thank you.
Thanks.
Thanks for your
Thank you
time.
so much.
Appreciate it.
Thank you so much.
Make sure you can, Amber, give us the team.
You don't want the cookies?
No, I mean, we don't grab them, but